This PowerPoint presentation talks about the SOAP note. What is SOAP note? What are the definition, right? So SOAP note can describe as a method used to document a patient's data, normally used by healthcare provider. So the SOAP note is a method of documentation by healthcare providers to write out note in a patient data. Healthcare provider can write it out note in the patient data along with the other common format such as the admission note or documentation the patient's encounter in the medical record is an integral part of the practice, right? So the SOAP note is help the workflow starting with the appointment schedule, patient check-in, and examination of the patient, and documentation of note, check-out, reschedule, and also medical billing. Additionally, the SOAP note serves as a general cognitive framework for physician or any other healthcare provider to flow as they assess their practice or with the patients. So SOAP note stands for S, subjective data, O for objective data, and A stands for analysis and assessment. Also, P stands for the plan. So first of all, here, the chief complaint. So when patient come to you, definitely you will ask, how can I help you? Or what are the reason you looking for medical care today? So chief complaint is a brief statement of the symptoms or of statement of the problem or condition or diagnosis or other factor that is the reason for encounter. The chief complaint of a patient coming in for follow-up care could be described as, right? Could be described as the patient return for re-evaluation of diabetic control as part of the healthcare provider order at last visit. I'm talking about the follow-up care, right? Some patient come to you because of the, like, imagine pain in the abdomen, or patient come to you fever for 7 days. So it is the chief complaint, fever for 7 days or pain for 2 days. But sometimes patient come to visit for the follow-up care or lab works. So what patient said or patient own word, we keep in note. Ask the patient why he or she has looking for medical care. Or what patient said we do not rephrase. Example, the correct way, I have had a runny nose and sore throat for 3 days. What patient said, we will keep it in note as a chief complaint. Incorrect way, what patient said, like this sentence, if you say patient stated that he experienced runny nose or pharyngitis for 3 days, it is not correct. Second here, history taking. So first of all, the history, comprehensive health history, and focused health history. So comprehensive health history means or we call say comprehensive health assessment. And the assessment there include the patient history or their physical examinations and vital signs. And this assessment or history are performed upon initial admissions and also uh, based on how you take the history by asking the leading questions. So patient history should include the patient's medical record or surgical history. And this is also the image is also including the patient's past medical history, family history, social history, also review the system. And second, we should focused health history. Focused health history means that the focused on something particular. The part of the, like I said, what the health history focused on might be, or for example, things related to the smoking or to the weight gain or weight loss or the age specific problem, right? Or if patient said, I have a pain in my left side of chest, you have to focus on cardiovascular system, right? So it includes identifying data, chief complaint, history of present illness, data from the patient's past medical history, family history, social history that are to the chief complaint, inflect to the chief complaint. Also, problem-oriented review of the systems. So next here, talking about the history of present illness. Shortly we call HPI. The goal is obtaining history of present illness is to get a comprehensive description of the characteristics and progression of symptom for which the patient looking for the medical care. The present history of present illness we categorized and how to memorize. So you have to ask the leading question by using PQRST. P stand for precipitating factor. Q stand for quality. R radiation. S for severity. And T for timing. Example, P precipitating factor. So what provokes your symptom? So what you do, your problem increase, or what you do, your problem release or go down. Also, quality means describe the character or location of the symptom. If I said I have a pain, you could ask, can you show me where actually it is by one finger? Or what are the nature of your pain? Quality, character. Also, radiation. Does the symptom radiate to the other area of the body? Severity. You could ask the patient to quantify the symptom on a scale of 0 to 10, with 0 being the absence of the symptom and 10 being the most intense. If patient said, I have a pain, 9 out of 10 means very severe pain. They need immediate care. And last one, T for timing. In about the onset, inquiry about the onset, duration, and frequency of problem, timing. And next, we're looking for character, location, inspect, expectations, neglect or absence, and timing. The common client outcomes, we can remember clients. See, character. So character of the symptom, including intensity and severity. L for location. Location including the radiation. And I for that impact of the symptom, illness on the patient's activities of the daily life, and also quality of life. E stands for expectations of the caregiver process, and N for negligence. So neglect or abuse, including any sign that is physical or emotional neglect or abuse, play a role in the patient's conditions. And T for timing. Timing improves the onset, duration, and frequency of symptom. And next here, we easy to remember outcome. So O for other symptom. So other symptoms that occur in presenting symptom. And U for understanding or brief. So understanding or brief about the possible reason or possible cause of the illness or condition. And T stand for the treatment. So treatment, I mean medical treatment or other therapies that the patient has used to try to alleviate the symptoms condition. And C stand for the complementary or alternative. Complementary and alternative medications, we call CAM, including a description of the patient's use of these agents, right? So some people use herbal medications, Chinese medication, we call alternative medications, and P stand for options. So options for care that are important to the patient, right? Like advanced directives, living wills, and M stand for modulating factors, exposed to infectious agents, toxic materials, and S stand for spirituality, including spiritual belief, values, and need of the patients. And next, we're supposed to talk about the past medical history. So, past medical history, patients' definitions of health and perceptions of the current health status. Past medical history, the patient past experience with illness, past experience, any kind of surgical operation, any kind of injuries and treatment. Let me recap it. The past medical history included childhood illness, major adult illness or conditions, any allergic history or past experience about medication or treatment, injuries, hospitalizations, blood transfusion, immunization history, any scanning examination. Like I have a uh, diabetic in my family, so it is important. I have to evaluate it, regular checkup. Also, psychiatric or mental history included. Family history. Is this genetic or under the risk? Why family history is important? So family history helps doctor or healthcare provider or other healthcare practitioners provide a better care for the patient. A properly collected family history can identify whether a patient has a higher risk for a disease or not. It helps the healthcare provider recommend the treatment or other options to reduce the patient's risk of the disease. So family history include measured illness or health status of the relatives, particularly father, mother, or sibling. Genetics defect. So if father or mother have a positive genetic defect, so when you take the baby, it is important to evaluate when death or the cause of death or ethnicities. Next, go social history. Social history and past and current. So if you social history of the patient, so keep in mind, so social history along with the chance to connect with the patients as a person, or the social history can provide the vital early the clues to the presence of the disease or guide of the, it helps to guide physical examination and test, ordered the strategies, and also facilitate the provision of cost-effective or evidence-based care. So social history included personal data, occupational data, housing, safety, socio-economical status, right? Because some of the disease is related to occupation. If I'm working as a farmer, I have a chance to develop lung disease. If I work in a rubber industry, I have a chance to develop bladder cancer. So housing also can reflect what are the economical status, socio-economical status. So if you reach and eat too much fat food, you have a chance to develop cardiovascular disease. If patient is really poor, they have chance to develop protein and nutrition malnutrition, kwashiorkor, marasmus, right? So dieting history, exercise important, sleep pattern, and also sexual history, right? How many partner or what are the patterns of activities? So drugs and alcohol abuse, social support, how you manage the stress, or you always under the stress and it leads to the anxiety or heart disease. So recreation of traveling history, like you came with a fever and you give me the history, you visited in some country what the some particular tropical disease is there, right? We need to evaluate cultural belief, practice, spiritualities, and also military services. Next is subjective data, also known as the subjective history. So present illness, history of present illness include symptoms, dimensions, chronological narratives of patients' complaint, information obtained from other sources. So subjective data is the part of history of the chip complaint to the review of systems. Whereas the objective data, what you detect during the examination, right? So subjective data, so patients has not had any stiffness or loss of motion of other joints. So subjective data include the history taking, like past medical history. So past medical history means patient acts to sign of the disease and the onset of the disease and review the patient's history of risk factor like cardiac failure, like shock. So like you take medication history. So the patient even or even taking any medication. So patient give you the information. What patient tell you, whatever their past medical history or their medication history, their family history, all is the subject. So ask any case at home of the similar condition, means the family history, also subjective data. So subjective data is the information provided by the patient or their family members or caregivers. Objective data is the information that can be obtained using the your five senses. So what you see, what you observe, what you measure, what you smell, what you touch. So what you detect during the examination, all physical examination findings is the objective data, subjective data. Sorry. Right? So physical exam and laboratory data section, vital sign, objective data include oxygen saturation or focuses physical exam, all lab values, X-ray. So blood work is the objective data, right? Next here, review of the systems. So the last component of the health history is the review of the system, shortly called ROS. The physician questions the patients about whether or not she or he has experienced the symptom that may indicate possible pathology in one or more body systems. The nature and depth of the questioning are determined by the reason for which the patient is looking for medical care, as well as the severities of the condition if she or he present within acute problems. So type of review of the symptom, comprehensive review of symptom, and focus review of symptom. So review of symptoms is a list of questions arranged by organ systems or designed to uncover the dysfunction and disease within that areas. So next, go little bit more about the component of the comprehensive review system. It including the general appearance, right? Like your body build, lookings, any deformities. Intragomental system evaluate skin, ear, nose, mouth and throat, cardiovascular system, respiratory system, gastrointestinal system, genitourinary system, evaluate the breast musculoskeletal system, neurological system, mental or psychiatric, lymphatic system, blood or hematology, also endocrine systems. Next of the footnote are assessment. So assessment means we, after the patient, look of the patient, ask some leading questions, monitor your patient, inspect your patient, we go for the assessment, right? So assessment section always done by the RN, right? So keep it note before to go the assessment patient, we collect the data by taking, as I told you, we collect the subjective data, objective data, and also confirm the data collections, right? So assessment include the problem list, your assessment of the patient's problems, also assessment a one sentence description of the patient's and major problem. Problem list, a numerical list of the problems identified. Provide at least two differential diagnoses of the major new problem identified in your note. So what should be the differential diagnosis? Right, at least two. Then sometimes diagnosis we call analysis also. So identify the actual or potential healthcare needs and problem based on your assessment. So also interpret the data, validate data, organize data, or determine if there is a need for more data collections. So in this phase, the healthcare provider use data to formulate we call nursing diagnosis. After the nursing diagnosis, we go for the plan or planning. So planning means determine the patient's needs. So you plan for the patients based on problem you have identified. Develop a diagnostic or treatment plan for each differential diagnosis. And your diagnostic plan may include the test, procedure, and other laboratory studies. Your treatment plan should include patient's education, pharmacotherapy, and you must also address the plan for. So the planning, this is done on provide the client care constantly and appropriately. Always when you make the planning for the patient, it is good to ask yourself the following questions. What are the priorities? Also, how does the determine the client needs? And how will this affect the care of the client become sick to well. It means become healthy. So this is the part of the soap note, right? Up to this for now, it is end. And Dr. Abul Kalam said, end is not the end. It means effort never die. So thank you for your participation.